Burn is an injury caused by exposure to thermal, chemical, electrical, or radiation energy. It usually affects the skin, but may also damage the airways, lungs, muscles, bones, or other internal organs. A scald is a burn caused by contact with hot liquid or steam. Scalds are the most common burn type, accounting for 70% of burns in children, followed by flame and contact burns. Non-complex burns, previously described as minor burns, are defined as any partial thickness thermal burn covering less than or equal to 15% of the total body surface area in adults, 10% in children, or 5% in children younger than 1 year. These burns should not affect a critical area. A deep partial thickness burn covering less than or equal to 1% of the body would also be considered a non-complex burn. Complications of non-complex burns include hypothermia, infection and sepsis, chronic neuropathic pain and itch, scarring. Burns that take more than 2 to 3 weeks to heal are more likely to result in hypertrophic scarring. Psychosocial impact, such as depression, anxiety, post-traumatic stress disorder, changes in body image, stigma, and social isolation following scarring. Complex burns, previously described as major burns, are any thermal burn or injury affecting a critical area. Critical areas are defined as burns to the face, hands, feet, peritoneum, genitalia, or burns that cross joints, and circumferential burns. Any thermal burn covering more than 15% of the total body surface area in adults, or 10% in children, or more than 5% in children younger than 1 year, and all chemical and electrical burns. In the UK, it is estimated that 250,000 people receive burn injuries every year. 175,000 people with burns attend ED departments. 16,000 people are admitted to the hospital for specialist burns care. In the UK, about 90% of burn injuries are non-complex. The skin is a barrier to bacteria and moisture loss. When this is breached, potential complications from burns may present soon after injury or later during the healing process. It is important to act fast with burns to stop the burning and perform first aid. After giving immediate first aid, ensure any burn is assessed rapidly and accurately to reduce the risk of progressive injury and complications. You must assess the timing, type, and cause of the burn, for example flame, scald, contact burn, electrical or chemical, and the mechanism of injury. The risk of inhalation injury, the possibility of a non-accidental injury. This includes looking at safeguarding issues for both adults and children. Look at symptoms such as pain or itch, and any comorbidities which may affect the wound healing process. Wallace's rule of 9 estimates the affected body surface area of an adult using multiples of 9 representing different areas of the body. Different calculations are used for children and infants. The rule of palm assumes that the palm, including the fingers, of the person who is burned is about 1% of the body. The extent of a burn injury is often described as degrees. A first-degree burn only affects the outer layer of the skin. The second-degree burn goes deeper into the underlying layers of skin. And a third-degree burn will often be referred to as full thickness, as the whole of the skin is affected. This table describes the depth of burn, layers of skin that would be affected, and what the skin would look like on examination for each of these categories of burn. When assessing a burns patient, it is important to still assess the patient's airway, breathing and circulation, and for the presence of any coexisting non-burn injuries or trauma that may be life-threatening and require emergency treatment prior to the treatment of the burn itself. When treating a thermal burn, it is important to first stop the burning process. For example, extinguish flames using the stop, drop and roll, or smother them with a blanket. You should remove non-adherent clothing and potentially restricting jewellery. Do not attempt to remove tar that is stuck to the skin. Within 20 minutes of the injury, the burn should be irrigated with cool or tepid running water for 20 to 30 minutes. Do not use ice or very cold water, as this may cause vasoconstriction and deepen the wound. If water is not available, use wet towels or compresses. Ensure the person is kept warm with coats, sheets or blankets to avoid hypothermia, especially if cooling large areas of skin in children or the elderly. Immediately after cooling, cover the burn using cling film, layered onto the burn rather than wrapped circumferentially to reduce the risk of vasoconstriction. Consider using a clean, clear plastic bag for burns to the hand. If cling film is not available, use a clean cotton sheet. Do not use wet dressings or topical creams. Elevate the affected area if possible to reduce the risk of edema. Offer pain relief such as paracetamol, ibuprofen for mild to moderate pain. Consider adding codeine for more severe pain. Assess the burn as to whether it would need specialist referral or off-island treatment. If the person has been injured by a low voltage source, such as domestic electricity supply, safely switch off the power supply or remove the person from the electrical source using a non-conductive material such as a wooden stick or chair. Do not approach a person connected to a high voltage source. Arrange for immediate admission to the emergency department, where transfer to a regional off-island burns unit will usually be necessary. With chemical burns, it is important to determine the chemical causative agent wherever possible. You should remove the affected clothing and brush off the chemical if it is in a dry powder form, and copiously irrigate the burn with water for about an hour. Do not attempt to neutralize chemicals, as additional heat could be generated, which may increase the tissue damage. Non-complex burns do not usually require specialist off-island treatment. However, non-complex burns have the potential to progress into complex wounds over time. Cleansing is useful for removing foreign bodies, soluble debris, excess slough or necrotic tissue, which may become a focus for infection. Cleansing is advised prior to obtaining a bacterial swab, but do not take swabs unless there is clinical evidence of a wound infection. If a clean technique is being used, use lukewarm tap water. If a sterile technique is required, use 0.9% normal saline. Ideally, the cleansing fluid should be at body temperature, or if this is not possible, the fluid should be warmed to room temperature before use. Do not clean wounds by scrubbing, which causes pain and local tissue edema. Irrigation is more protective of the fragile tissue. Do not use topical antiseptics due to reported pain, tissue damage, wound drying, and ultimately delayed healing. Debridement describes the process of removal of necrotic, devitalized, sloughy, or infected tissue. This allows visualization of the wound bed and encourages epithelialization. Natural or autolytic debridement may be promoted by the use of specialist dressings such as hydrogels. specialist surgical debridement may be appropriate and will need a tissue viability referral. Wherever possible, blisters should be left intact to reduce the risk of infection. Blister and oedema management is important as they can put pressure on the underlying dermis and can reduce skin perfusion and potentially deepen burn injuries. Consider de-roofing large blisters, for example, those greater than 1 centimetre squared. Blisters that are likely to rupture or are over a joint. This must be done using an aseptic technique. The choice of dressing will depend on the site, size and depth of the wound, the level of exudate, infection risk, and on local formulary availability. An appropriate size and type of dressing should be selected to avoid stretching or applying dressings under tension. The wound should be covered with a non-adherent dressing, such as paraffin gauze, silicone-coated nylon, or a hydrocolloid. A secondary, non-fibrous absorbent dressing, such as a dressing pad, should then be applied and secured well with a lightweight conforming bandage or tubular gauze. Dressings should be changed regularly to encourage wound healing. Once burn depth is accurately estimated, the frequency of dressing change may be reduced to minimize the risk of bacterial contamination and trauma to the wound. If appropriate, the person or a carer can be supported to change their own dressings. Appropriate analgesia should be taken prior to every dressing change. Do not use systemic or topical prophylactic antibiotics, antimicrobial impregnated dressings, antimicrobial creams, or other topical preparations. The aim of good wound management is to provide a moist environment to promote re-epithelialization and prevent wound progression, dehydration, and infection. This table is taken from our local dressings and tissue viability policy. The right-hand column suggests locally available dressings that could be used for burns patients. If there is any doubt as to which dressing should be used or any concern over a burn, please contact the tissue viability nurses. If you suspect that a burn is becoming infected, clean the wound with 0.9% sodium chloride or lukewarm tap water. Take a bacterial swab and inform the doctor in charge of the patient's care. They may wish to start empirical antibiotic treatment. Also ensure that analgesia is prescribed, such as paracetamol or ibuprofen, as infected burns can often become more painful. This necessitates a referral to the tissue viability nurse.